Hello, welcome all. Coming on to the session two of the Structure Heart Academy. In this particular session, I would be discussing a bit about the balloon metal valvotomy. It is commonly done in Asian countries, especially in India. In the first session, I've discussed about this transeptal puncture, and now once we are aware about how to do perform the transeptal puncture, then we'll move ahead to how to perform the balloon metal valvotomy. Once the good transeptal puncture, a safe transeptal puncture, we can see the dye going inside the left atrium. And after that, the next thing is the coil wire. The coil wire is passed into the left atrium. And once the coil wire is through, then after that, after dilatation the septum, we can see that what sometimes we need to reshape the stillet. J-shape stillet is placed inside the balloon, and if the puncture is high, normal or low, then we sometimes in need to change the curvature of the stillet accordingly. So, septal puncture we have discussed. So, once we are through and we have dilated adequately the septum and we have crossed this coil wire inside, then slenderized balloon is now inserted in LA over the guide wire. And once in LA, then golden tube is removed along with the straightener, that is the silver tube. And it is always silver first, then gold in both, getting inside and getting outside. So once we are through the two-third of the IES, then we just release the this silver portion, and then we'll move the golden tube as well, and the balloon will coil over the wire, and slightly inflation of the balloon at the tip is usually required to prevent the slipping. This is how most commonly used balloon looks like. It is an inner tube that is golden, is connected to the polythene tube which form the central lumen, and the straightness passes through this golden tube. So these are the various hardwares required in this. We also have this connectors, vernier calipers, this J-tip, um, and this is the coil wire, and this is the inner tube. So this is the cross section of the this balloon. We show center lumen, vent tube, and a security thread, and four as the shaft. So these are the structure which can be seen. So once we are in the left atrium, then in LAO, we push it along the lateral wall of the left atrium and try to make a U shape so that it goes against the AML. And then we'll go to the RAO, and after removing the guide wire stillet is introduced in the balloon as per the this point of entry, and it is a bit will put a bit of anti-clockwise turn till it faces the LV, and the bobbing of the balloon or the popping action of the balloon denotes the balloon tip is facing the mitral valve. And with the accordion maneuver, you'll just pull the wire, and then the balloon gets entry inside the LV, and the stillet is pulled and the balloon is put. This is called accordion maneuver. And if the left atrium is enlarged, then of course we try to push the balloon slight clockwise, and once we are pushing it clockwise, it can be that it will take a reverse loop, and it is usually required when the puncture is low and LA is large. So in this, the stillet is rotated clockwise, and this forms a reverse loop and might have entered to the floor. So this is an anatomical variation. And once we are in, after the balloon crosses across the mitral valve, the distal portion of the balloon is inflated more fully, and the catheter is pulled back gently to confirm that the inflated distal portion of the balloon is secure across the valve. And as further volume is added to the balloon, the proximal end inflates to lock the valve between the proximal and the distal balloon. And inflation to the pre-calibrated volume then dilates the orifice valve to the corresponding preset size. Uh, Stepwise dilatation is important. The nominal balloon diameter is measured by the height divided by 10 plus 10. So it's the balloon diameter. And first inflation is performed to a balloon of 2 millimeter less than the nominal, followed by the successive incremental inflammation by 0.5. After seeing the commissural split and seeing there is no severe MR, then of course we can increase the volume by 0.5 to achieve the optimum balloon diameter. So this is how once we are doing this BMV, then one catheter is in the LV, we can see the ventricular trace in the form of white trace, and in the yellow trace is the this atrial pressure. And at the end, at the QRS, at the peak of R, if we go to the end diastole, we can see there is 5, 10, 15, 20 millimeter, 22 millimeter of end diastolic gradient before the BMV. And once the BMV is performed, the gradient, the V waves, which was initially 28 millimeter, has gone down to this less than around 16. And this end diastolic pressure has come down below 5 to 6. So this is how we should see the V wave decrement and the end diastolic pressure decrement. This is suggestive of a reduction in the gradient, or going gradient below 5 is the thing that we want to achieve in the absence of the severe MR. And once we have dilated the balloon, then the balloon is recylindrized by first introducing the guide wire and then stretching and then the stretching tube. And it is useful to leave the guide wire across the septum LA for 3 to 5 minutes after the completion procedure by monitoring the systemic arterial pressure. Then this many times various problems can be encountered. So in the presence of kinking of the balloon, if the gold tube is pushed in balloon without a stenotor, it results in kinking. So while withdrawing, both gold and a silver tube should be removed together. So just refocusing or reinforcing the first basic steps in BMV are transeptal puncture, record the pressure between LA with the Molin sheath or with LV in the pigtail with another catheter, that is a pigtail in the LV. Then after performing the dilatations, then heparin once the coil wire is in the left atrium, then introduction of the balloon in the LO with the straightener, then the straightener is removed, balloon is advanced over the coil wire in LA, and the mitral valve is tried to cross with the stillet and with a slight anterior curvature with the 2 to 3 anti-clockwise rotations. And then the stillet should be withdrawn and that advance the balloon towards the apex. And we should see the free movement once we cross the balloon. Then we should try to take the balloon to the apex and try to pull the balloon, whether to prevent it from stucking in the subalveolar structure. And we'll go with the serial dilatation of checking the commissural split in the echo. And after that, we should assess by the planimetry, and we should see we have not caused any tear or the MR, and we should look for any tear or caudal damage. And if it is there, then we can think of sending the patient to surgery. And commissural MR usually uh, improves in the due course of the time. A successful BMV is defined as a split of one or more commissure with increase in mitral area of at least 55% from the basal area and final mitral area more than 1.5 centimeter square, and in the absence of the significant mitral regurgitation. So these are the steps we have after the transeptal puncture. The coil wire is in the left atrium. Then we are dilating this intermittent septum with the dilatator. Then we are introducing the balloon. Then after this, the wire are removed and the slightly inflating the distal tip, we try to push into the left atrium, then taking it across near the anterior tip. Then we try to introduce the balloon with the accordion maneuver into the LV across the mitral valve, and then a dilatation is done. So these are the basic few steps that can be seen in this slide. And once we have so usually we nowadays do the single balloon mitral valve dilatations, but as we can see, a balloon of 26 will generate more pressure than inflated to 26 as compared to the 30 balloon when inflated to 26. So many times this high lateral pressure dilates thick fibrous septa but may lead to a valve tear. So to prevent the injury to the valve, size of balloon reflects maximum size of the middle part of the balloon, and each balloon can safely be inflated 1 to 2 millimeter above the nominal size, and the balloon catheter is 12 French and length is 70 centimeter, and the length of the unstretched balloon is this 2.5. So many times, if we are not able to achieve the good area by the single balloon inflation, then we can many times, some operators use double balloon technique, although not done much nowadays. This is how double balloon valvotomy looks like to achieve more gain in the limb in the valve area. There are some other balloons that have been developed. One is like multi-track balloon, which is shown. But there are, of course, some complications. IMR can happen and can range up to 2 to 9% due to the tearing or the stretching of the commissures, or maybe due to the AML tear, or rupture of chordae or damage to the papillary muscles. And there are some, of course, procedure-related major complication can happen, like embolic event can happen in 1%, and septal puncture-related complications that can have a pericardial effusion in approximately 0.5 to 1%. And of course, there can be residual ASD in 5% of the cases, arrhythmias, liver-related complications. So, what are the few precautions that clinical evaluation as well as the a good proper echo to see the scoring, the whether the valve is flyable or not, should be done prior to this BMV, and appropriate size selection and the preparation of balloon should be there. And we should be sure that balloon catheter is in the free LV cavity after mitral valve has been closed. If the balloon is having angulated course during LV entry and appearing entangled with chordae tendon, the balloon is withdrawn and then balloon is passed again. So, and if we are seeing any subvalvular denting in the distal part, then that is the place where we should not dilate it. So this is how the proper, after this septal puncture, after crossing the balloon, this is how the proper dilatation looks like. Many times there would be problem in the subvalvular structure that should be identified. So there should be uniform opening of the valve. And if there is problem in the IVC, then of course there are some cases where the transjugular route have been used to cross the this septum from this jugular route, and the BMB have been performed. So these are the various other routes which have been found to be useful in the case where the inferior vena cava anatomy. And sometimes after a lot of efforts, we are not able to cross the wire. Then many times over the wire technique can be used in case of large atrium, left atrium, thick IES, low IES puncture, and many times if there is a LA clot or left atrial appendage clot, then this over the wire technique, taking this hydrophilic wire, telomer wire has been used to cross the valve. And over this, we can go with this over the wire technique. This is how this balloon was crossed, and the BMV was performed in a difficult entry into the LV. So thank you all for patient listening. This was all about the session 2 in which we discussed about the balloon mitral valvotomy, and we would be coming in next session with a further structural heart interventions. Thank you all.